Welcome back. Here, let's look at heart failure. When you say heart failure, it's the inability of the heart to pump enough blood to cope with normal functions within the body. Okay? Inadequate perfusion of tissues and ultimately leads to death. Okay? It's the disease of the elderly. The common age group is 65 and above. Okay, so here it shows the numbers 20 out of 1,000 between 65 to 69 versus at age 85, it is 40 out of 1,000. So it has doubled by age 85. And among all ethnicities and between male and female individuals, it is most often the male, especially the African American male, that suffers from heart disease the most. Okay, now this is just an overview where we talk about what are some key causes of heart failure. Ischemic heart disease tops. Ischemia, because of the poor design of blood supply to the heart, that leads to loss of muscle fibers, and that leads to the loss of the ability of the heart to pump blood. Cardiomyopathy is where the muscle fibers are abnormal, genetic, acquired, or a combination of those. Valve disease, this is specifically cardiac valve disease. Okay, so regurgitation, stenosis, leading to abnormal hemodynamics, affecting the heart function. Hypertension adds additional workload to the heart, and that's how the heart cannot keep up with this demand and gives up. Pericardial abnormalities, where pericarditis, cardiac tamponade, all those conditions may have their weight on the heart and make the heart fail to function. Pulmonary hypertension is where the blood has to be oxygenated and taken to the lungs, and if there is hypertension, blood flow to the lungs may not be normal. So blood backs up in the heart and backs up in the veins, and all of this indirectly affects heart function, directly or indirectly. So good, with this introduction, let's talk about the classification of heart failure. You can describe heart failure in many ways. Sometimes there is an overlap, systolic versus diastolic. All right, so systolic is where the heart has enough blood, but it cannot pump. Okay, diastolic is where you have less than normal amount of blood in the heart, but the contraction process is fine. So it's the filling problem we have. Okay, acute versus chronic. Acute is where it's sudden cardiac ischemia, MI. Okay, no warning here. Versus chronic, one has a heart disease, the heart is failing, it's a matter of time. left-sided versus right-sided. Well, sometimes left-sided can cause right-sided heart failure. Okay, so left-sided is where the left ventricle is affected, and then that's how blood is not pumped. Right-sided could be affected when there is pulmonary issues. All right, sometimes the left-sided affects the right-sided heart failure. High output versus low output. Okay, some conditions cause less than normal blood being released, and some conditions make the heart pump more blood than usual. Okay, so either one will ultimately lead to heart failure. Okay, so those are different types. Now let's talk about the pathophysiology itself that's behind heart failure. Okay, so you're talking about pressure overload in the heart. Okay, stiffness of the heart, fibrous tissue within the myocardium, lack of contractility could be the cause of pressure overload, volume overload. So because the heart cannot pump blood, okay, the blood may sit in the ventricle and then more blood arrives. And so this is just a complication of more blood in the heart over time. MI, myocardial ischemia, myocarditis, inflammation of the myocardium, restricted diastolic filling. Again, this is where you have high pressure in the ventricle because of the stiffness, so the blood cannot arrive in the ventricle. So it backs up. Okay, so these are conditions that could, initially use adaptive mechanisms. Okay, so what are some of those adaptive mechanisms? They're listed here. Initially, the heart may try to overcome these issues by increasing stroke volume. That is if possible. Some conditions may not allow this particular step. All right, activation of the sympathetic nervous system. So anytime there is decreased output, then the negative feedback mechanism is to increase the sympathetic system to help bring conditions back to normal. So that is quite common. Alterations in the inotropic state, that is the contraction state. You may want to increase the contraction state. Heart rate, we already talked about stroke volume, so here we are talking about heart rate. And alteration in afterload. Okay, decrease the afterload to increase the cardiac output. Humoral responses is where you're talking about a number of hormones that may be released to help with the condition, one or another, that is. And some of those hormones may trigger myocardial remodeling. Not all of those, some of those. All right, so these are some possibilities. We will expand on these a little bit more in the next set of slides. Okay, here is Frank Starling law of the heart. Very, very simple. What it's showing here is the end diastolic wall pressure, okay, ventricular end diastolic pressure, and a stroke volume. So if there is so much volume, okay, that is how much pressure there is, okay. So the amount of blood that sits in the ventricle determines the amount of pressure that's in the chamber. And now what it is if the contractility is reduced. Okay, the pressure is less, and therefore what you see is this is stroke volume less than normal. So there is less pumping happening. Okay, reduced contractility means there is less force of contraction. That means less blood being ejected. So this is Frank-Starling law of the heart. This is just showing different situations. A normal function is where, there is so much contraction force and therefore it is perfectly fine. Increased contractility is increased force of contraction, increased force within the left ventricle to push more blood out. So it's plain physiology. Okay, so for us to be able to pump blood, we depend on the contraction force, and then greater the contraction force, greater the stroke volume, and so on. Okay, so this may be affected in some of the conditions, and therefore stroke volume may be reduced. Now, what about sympathetic activation? Well, what are the results of sympathetic activation is what is shown here. Well, sympathetic activation causes total peripheral resistance, increased total peripheral resistance due to its ability to cause vasoconstriction. Okay, so that would help maintain blood pressure, normal blood pressure, or may even increase it, and maintain venous return. So this pressure is needed to bring blood back to the heart, and that helps maintain stroke volume. So enough venous return, then that means in the diastolic volume would be normal. In diastolic volume being normal results in normal stroke volume. Sympathetic activation also increases the contraction force. So that's where it keeps up with the situation for a little bit longer. So this is the activation of sympathetic system when the pumping ability is reduced, stroke volume may be reduced. And now how does the sympathetic system fix it? Is by increasing the vasoconstriction, and that would help maintain normal blood pressure, and that would help bring blood back to the heart and increase stroke volume. Activation of the sympathetic system decreases blood flow to the kidneys. Okay, so it shunts blood to systems that are, essential at the time, like respiratory, muscular, cardiovascular, and nervous systems. But blood is, blood supply is reduced to renal and digestive system. So here you're focusing on the decreased blood flow to the kidneys. That means when there is less blood arriving in the kidneys, that is a trigger for the secretion of renin, which then brings about angiotensin II and aldosterone. That would lead to reabsorption of sodium and water. What does that do? Increased blood volume, blood pressure, and cardiac output. So here is another way to improve cardiac output. Epinephrine and norepinephrine released because of the activation of the sympathetic system may trigger ventricular remodeling. Okay, too much of epinephrine and norepinephrine may be toxic to the myocardial cells, necrosis of these cells, replacement of these dead cells by new cells is the issue here. And what happens is ventricular remodeling is fine, but these muscle fibers do not participate in muscle contraction. So this becomes a nuisance, ventricular remodeling. And also note that these compensatory mechanisms are good, but it can only last so long. Over time, the overactive sympathetic system wears off. So that's how these systems fall apart over time. We will look at inotropy, afterload, heart rate, humoral mediators a little bit as well. Inotropy is the ions that are present that would be positive for the cardiac function, that is calcium ion. Here you're talking about decreased contractility, as remodeled myocytes do not participate in contraction. Okay, so inotropy is not helping. Afterload, whenever there is increased vasoconstriction, that increases afterload. Increased afterload is not a good situation for the heart, because the heart has to pump extra hard to overcome this afterload and pump blood. So the stroke volume would become less and less. In heart rate, because of the activation of the sympathetic system, there is increased heart rate, tachycardia. Humoral mediators would, anytime there is increased blood pressure, the heart itself releases some hormones. Those are atrial natriuretic peptide. Okay, there are A and B types of those, so they're called ANP and BNP. Atrial natriuretic peptide is supposed to reduce blood pressure. They have many other benefits as well, but like removing more sodium ion, getting rid of more water, and having the opposite effect on the kidneys as that of sympathetic system. Instead of turning on an angiotensin aldosterone pathway, it would be turning off of the renin-angiotensin aldosterone pathway. So those are all some effects of ANP and BNP. But as I mentioned, their effects are not going to be as well regulated in this situation. Decreased response to hormones is how you would not be utilizing the benefits of these hormones in a heart failure condition. Here is a beautiful illustration of some of the mechanisms. These are causes: coronary artery disease, hypertension, cardiomyopathy, valvular disease. The major ones are shown. Left ventricular dysfunction, okay, leads to remodeling, and remodeling would reduce the contraction force and reduce the ejection fraction. Okay, remodeling and other things going on in the left ventricle can be seen in the ECG readings and causes death. Okay, now low ejection fraction may lead to pump failure, and that may lead to chronic heart failure. Okay, so chronic heart failure, pump failure, all of these lead to death. Non-cardiac factors may be involved as well. Left ventricular dysfunction and non-cardiac factors that may be involved, something other than the heart failure is what you're thinking about triggering remodeling. It could be a genetic condition, for example. Okay, so that could also cause all these effects. Non-cardiac factors may involve additional symptoms, which may lead to chronic heart failure. Okay, good. With this, let's look at systolic heart failure in detail. This is where, remember, the heart cannot contract to pump blood. Okay, filling is normal, contraction is an issue. Okay. So here we are looking at an example. Less oxygen supply to the heart muscle, loss of muscle fibers, then weak left ventricular wall. You see, the wall is supposed to be very muscular and very capable, but now it's not so. Decreased left ventricular ejection fraction, obviously, and increased preload. That means more blood sits in the left ventricle. That's what causes S3 sound. S3 is an abnormal sound heard during early diastole. Early diastole is where there should be less blood, right? Then, I mean, there is that ESV, but here you have more than the normal ESV in systolic volume. Heart muscle grows outwards, that is eccentric hypertrophy, and increases left atrial pressure, left atrial hypertrophy. So this is all like one leading to another. Increased pulmonary pressure eventually. Extravasation is because of the increased pressure within the lungs. The uptake of the absorption of fluid from the interstitial space back to the pulmonary capillary doesn't happen. Okay, so capillary exchange is where we discuss the details of this. The main message here is more fluid remains outside of the capillaries. So that leads to edema. Extravasation is fluid is building up within the lung tissue, okay, outside of the capillaries, causing pulmonary edema, and blood backs up in the pulmonary artery because of the high pressure in the lungs. Blood flow is not normal. Blood backs up in the pulmonary artery, right ventricle, right atrium. If you know the pathway of blood flow, you can now trace it backwards. If it's not getting into the lung, it's in the pulmonary artery, and then in the right ventricle, and then in the right atrium, and then ultimately in the blood vessels. Okay, veins will be now expanding with blood. That leads to peripheral edema. Okay, so those are consequences of systolic heart failure. Okay, now diastolic heart failure is where the filling heart is an issue. Contraction is fine, the filling is not fine. What is the problem? There is increased pressure. Okay, the left ventricle has lost its ability to fill due to concentric hypertrophy and the higher pressure within the chamber. Blood gets backed up, heart failure with preserved ejection. So anytime you see diastolic, you will use the term preserved ejection fraction. Okay, anytime you see systolic heart failure, it is reduced ejection fraction. Okay, so preserved ejection fraction, meaning it can contract, but it doesn't have enough blood to release. A decreased compliance of the left ventricle is the main cause of this. Here is a nice comparison of diastolic heart failure and systolic heart failure. Okay, now diastolic heart failure is typically among elderly, whereas systolic is among 50 to 70 years of age, because ischemia and MI are typically around this age. And diastolic heart failure is mostly female, whereas systolic is mostly male. And remember, preserved is the term we use. This is where equal to 40% or a little bit higher than 40% for diastolic, whereas less than 40% are equal to 40% in systolic. Okay, and this is where you call this depressed or reduced. Left ventricular cavity size is not dilated, normal, because of the hypertrophy ventricular hypertrophy, concentric is where additional muscle fibers are added. That's where the space is limited, size is not. Okay, whereas here dilated in the systolic. Chest chest X-ray shows congestion and cardiomegaly, maybe not. That is to do with the atria and the right side, probably because of the left side abnormality. Congestion and cardiomegaly are typical of systolic. Gallop rhythm present. Fourth heart sound is heard in a late diastole. Third heart sound, S3, is heard in early diastole. The fourth heart sound is because of the atrial systole and atrial filling with blood because of the backup. Correct? Now, hypertension has a role in both places, more in diastolic heart failure. Diabetes, yes, has an impact in both. Previous myocardial infarction has more in systolic heart failure. Obesity is more in diastolic heart failure than systolic. Chronic lung disease would cause the ventricle to become stiffer. Okay, some conditions would, this is COPD, for example, would affect the heart function. Okay, fibrosis of the cardiac muscle, COPD, release of inflammatory agents, and how that affects the heart is where lung disease would affect diastolic. And that is not the case with systolic. Sleep apnea is true of both conditions. Dialysis would affect diastolic heart failure. Atrial fibrillation is usually paroxysmal, meaning on and off, usually persistent in systolic. Okay, a very good comparison. Let's talk about acute and chronic heart failure, just the definitions. Acute, as I mentioned, sudden heart failure that could be because of worsening chronic heart failure that was always there, but it suddenly took off in south. New onset heart failure is where an MI or a cardiac valve rupture are some examples. Terminal heart failure, that's refractory. Okay, so now it's heart failure for Rio and requires emergency therapy. Chronic heart failure is associated with long-standing cardiac disease, so you know that this is there and you cannot help because of the age or other comorbid conditions the patient probably has. Okay, left-sided and right-sided heart failure is where one can be independent of the other or maybe interdependent. So increased ventricular pressures lead to fluid accumulation. So if there is, this applies mostly to left ventricle here. If you use the left ventricle as an example, increased left ventricular pressure would result in fluid accumulation in the left atrium and in the lungs and ultimately in the right side of the heart and ultimately the venous system. But if you consider this as the right ventricular pressure, that's possible too. Okay, there is additional muscle fibers, concentric muscle growth, eccentric muscle growth. Any of these could result in increased ventricular pressure within the right ventricle. Then what happens is the blood backs up in the veins, so fluid accumulation upstream. Upstream could be veins, the atria, the right side of the heart or the lungs. Okay, and then the heart failure. Here we separate them into left-sided and right-sided. So we will look at all these details carefully. Okay, left-sided heart failure is where increased end diastolic pressure because of the end diastolic volume. All right, so pulmonary venous congestion and diastolic pressure being higher would do what? You would not be able to bring blood into the left ventricle if there is high pressure. This is not the dilated type of cardiomyopathy, but it is instead restricted cardiomyopathy, all right, where you have stiffness, you have increased pressure than usual within the left ventricle. Then it could be right ventricle too. What happens then is blood backs up, and therefore there is pulmonary venous congestion. All right, so how? Because of the pressure being greater in the left ventricle, there is going to be blood backed up in the left atrium and ultimately in the lungs. Okay, so that is the consequence, and then that could extend to the right side of the heart. All right, clinical manifestations, so these should be pretty common at this point. Dyspnea, that is difficulty breathing. Orthopnea is whenever you're active is when you feel difficulty breathing. Pulmonary congestion and edema are the causes of these breathing changes. Fatigue, less urine output because of less perfusion, less stroke volume, right? Pleural effusion with hydrothorax. Pleural effusion because of the amount of fluid that's in the lungs. Some of the fluid leaks out into the pleura, and hydrothorax. So that is how the fluid accumulation happens within the pleural space, and that's referred to as hydrothorax. Increased respiratory rate to compensate for these things. Rhonchi, rales, or abnormal sounds during breathing. Jugular venous distension, that's because of the blood backing up in the venous system. Displaced apical impulse. Well, if you want to hear the heart sounds, they may not be in the same location because now the heart may have expanded. That cardiomegaly is where the displacement of apical impulse applies. Electromechanical dissociation, again, the enlargement of the heart is where the conduction of action potential may not be the same, but now different because of the abnormal size. Cyanosis, hypoxic signs, that's because of the decreased oxygen supply because of decreased blood supply. Right-sided heart failure is where you are looking at many causes. One of them is left-sided heart failure is the main cause. Okay, left-sided lesion. Okay, again, that fills the left atrium, and then the lungs, and then the right side of the heart. Cardiomyopathy could affect the right side or the left side equally. Pulmonary hypertension can affect the right side. Why? Because the blood flows from the right ventricle directly into the lungs via pulmonary artery. Okay, and now pulmonary hypertension is where pulmonary artery will have blood, but it cannot reach the lungs. Okay, so blood backs up in the right ventricle and eventually right atrium. Okay, so tricuspid and pulmonary valvular disease could be another cause. Also can result from diffuse hypoxic pulmonary disease. Again, lungs being non-functional, can interfere with the flow of blood and then backing up in the right side structures such as right ventricle, right atrium. All right, so now what we're talking about here is increased left ventricular filling pressure, increased left atrial filling pressure. So this is like a step-by-step change that would increase pulmonary pressure, and that reflects back into the pulmonary circulation, causes systemic venous congestion. Anytime there is a right side failure, you have congestion in the right ventricle, right atrium. So now blood backs up into the veins that typically bring blood back to the right atrium. So now that leads to peripheral edema, jugular venous distension, and congestive hepatomegaly. That means enlarged liver, because blood backs up into veins, including the liver, okay, closest to the heart compared to other organs, okay. Now, here is one explanation related to right-sided heart failure, lung disease, how it can impact. I would start here. Whenever there is lung disease, there is increased pulmonary vascular resistance, there is increased pressure, and so that interferes with the right heart. How? Increased force of right ventricular contraction to overcome this resistance. All right, that means increased demand for oxygen. You see, if the right side has to work hard, right, half of the heart has to work hard, its demand for oxygen increases. Okay, so what happens? Right ventricular hypoxia, and then decreased force of right ventricular contraction because of hypoxia, and increased right ventricular end diastolic pressure. This is where you have to assume a couple of things. One is there is a loss of muscle fibers. That is how we have new muscle fibers, and then regeneration, and they are not participating in muscle contraction, limited space in here. So all of that leads to increased end diastolic pressure, okay? Basically loss of elasticity and stiffness because of the loss of muscle fibers, okay, in the right ventricle. So what happens there? Increased right ventricular preload, increased right atrial preload. So I think this is where you have to say less preload. You're not able to fill with high end diastolic pressure, okay? So this leads to right atrial preload, and that leads to peripheral edema. And here, lung disease typically causes less oxygen to be available, and that leads to hypoxia, death of muscle fibers, and then the loss of muscle fibers leads to loss of the stretching capacity of the muscle fibers or the chambers, and then there is increased end diastolic pressure that backs the right atrium with blood, and that leads to peripheral edema. Okay, good. Low output and high output heart failure. So here, what we are looking at is cardiac index. A normal cardiac index is anywhere from 2.2 to 3.5 liters per minute per square meter. What this is you may have never come across this number, and for the first time, let's talk about this. So this is the output per body size. Okay, so this is not like 5 liters of blood ejected per minute. It is like this person weighing this much, the size of this much, would release this much blood, is the kind of math. So that is what you call as a normal cardiac index. That is typically these numbers, okay? So cause of low output heart failure is where less than this amount is what you're talking about, is where a coronary heart disease, cardiomyopathy, hypertension, valve disease, and pericardial disease. So those are all related to more or less the heart pathophysiology, isn't it? So now, high cardiac output disease, heart failure. So if you have low output heart failure, what that is you release less and less blood, and ultimately this reduced volume is not enough to keep up with the body function. That's how the body fails to keep up and dies. So that is low output heart failure. Cardiac output being high in special conditions like anemia. Okay, you have to increase the demand for blood in this condition. Pregnancy is another condition. Atriovenous fistulas, severe hypothyroidism, that is where the hormone is asking the heart to pump more blood. Beriberi is vitamin B deficiency. Okay, one of the effects of that is it causes vasodilation as well as the increase in cardiac output. Okay, and the Paget's disease is where increased vascularization causes the heart to pump more blood. Okay, so anyway, so those conditions demand more blood from the heart, and then the heart can only keep up for so long and it quits. You know, pregnancy is not as harmful because once in a while, right? But others can be, you know, constant demand, and that's where the heart may give up, and the heart failure is the result. Okay, so ventricles fail not only because of increased hemodynamic burden, but also because of direct myocardial toxicity. Okay, thyrotoxicosis and beriberi, or myocardial hypoxia caused by severe and prolonged anemia. Okay, good. Now, congestive heart failure. Congestive heart failure is already discussed in other heart failures. One of them we talked about is systolic heart failure. So again, just talking about congestive heart failure is where let's define it appropriately. MI is the most common cause of loss of contractility and increased preload. Blood is sitting here, then not being able to be ejected, correct? So let's take a look. Increased preload stretches the myocardium, and then the stretching is so much that there is decreased contractility. Increased preload, decreased lumen of coronary arteries. Okay, myocardial ischemia. So what it is saying is increased preload compresses the coronary arteries. Decreased lumen is a way of saying compression of the coronary arteries supplying the ventricle. So preload, there is volume, increased volume would make the wall kind of expanded, and that would also have the high pressure here that would lead to constriction of the coronary arteries, and therefore less blood reaching the heart, and that leads to ischemia and loss of muscle fibers, causing decreased contractility. Increased afterload is most commonly from increased peripheral vascular resistance. Okay, sympathetic activation or hypertension, conditions like that would increase afterload. And because the afterload is so high, the heart may not be able to generate so much pressure to overcome this afterload, and that's where the stroke volume is reduced and preload is greater than normal. All right, the last detail here is functional classification of heart failure. Here, you want to look at 1 through 4, 4 being the worst condition compared to 1 and the other intermediate ones. So let's talk about class 1. Ordinary physical activity does not cause symptoms of heart failure. So you probably are not aware of any of the heart condition yet. The part, class 2 is where symptoms occur with exertion, okay? Orthopnea and stuff like that. So symptoms, class 3 is where symptoms occur with less than ordinary exertion, okay? So it's kind of there all the time. Class 4 is where symptoms occur even at rest. So it's chronic, it's there, reminding you, and that is the worst condition. Classification based on progression of the disease is where you can organize it into stage A through D. Okay, so here you're looking at stage D as the worst, stage A as the early stage. Okay, stage A, patients at high risk of heart failure but without structural heart disease are symptoms of heart failure. Stage B, patients with structural heart disease but without symptoms of heart failure. So here they have structural heart disease. Here there is no structural heart disease in stage A. Stage B, there is structural heart disease but no symptoms. Stage C is where structural heart disease with previous or current symptoms of heart failure. So both are present, structural as well as functional. Stage D, refractory heart failure requiring a specialized intervention. So there is heart failure. Now you need to do something about it. Okay, so that's where you would stop. Okay, so heart failure, different types, and the mechanisms involved here is what we have discussed. Alrighty, thank you.